Here it is today. We have another synopsis. I'm going to be talking to you today about cardioversion. My name is Garfield Hamilton from CPR Health and Safety. I'm one of the instructors over there. I've been a BLS instructor for a long time. And, I started teaching ACLS. I realized that some of the times when it comes to people who are dealing with the BLS, working in teams, we have to recognize and be able to recognize the need for advanced measures as far as electrical therapy is concerned. Traditionally, for the BLS procedures, what we find is that our patients, they're an AFib, they're unresponsive, they're not breathing, no pulse. Well, we do have situations where, you have a patient who is responsive, he is talking to you for the most part, most times, but his heart is out of whack. It's just beating out of measure. So we're going to talk today a little bit about cardioversion, just how to recognize it. It's one of those situations where a person's heartbeat is really too fast, and we've got to do something to slow it down. Typically, as far as electrical therapy is concerned, there are some patients who are bradycardic. We've got to bring them up to where they need to be by pacing them. Then there are those who are tachycardic, and we've got to do something to try to get them back to normal sinus. So here we go. Cardioversion. What, when, and why? All right. So what is cardioversion? Cardioversion, if we take a look at this, is typically going to be a patient who has some form of arrhythmia that's it could be stable or unstable, but what we do realize is that the rhythm is not normal. Okay, the cardioversion is primarily used for rapid heartbeats to stabilize any type of arrhythmia. All right, so there are different ways that we're going to be dealing with the different type of arrhythmias. Again, this is just an overview. Um, as we said before, basic life support always comes before advanced life support. So while good BLS is important and our primary focus in cardiac arrest, when there is use of an AED, a simpler device, or a procedure, where we just shock common rhythms such as VFib, that's generally what happens on our cardiac arrest. Sometimes we're using a manual AED, those that move around. Or assessment of the patient can lead us to patients who have irregular rhythms that can possibly lead to cardiac arrest unless we intervene. So cardioversion is one of those interventions, obviously, that we would, want to use. Right, so why should we cardiovert? All right. Cardioversion, again, is done to prevent possible VFib from a tired or overworked heart. Right. So if we fail to recognize and act quickly, this could lead to complications. It could be cardiac arrest and possibly death. Okay. All right. So there are different type of arrhythmias. What type of arrhythmias do I cardiovert? Tachycardia is gonna be our primary rhythm that we want to slow down. Okay, heart is beating too fast. Usually the rates are over 150, and that could be a narrow complex, a wide complex, and it could be stable or unstable. So the question is, how do we treat these? And that's determined by whether or not the patient is stable or unstable. Whether it's tachycardic rhythms, whether it's narrow or wide. If they are stable, it's a whole different synopsis. As if they're unstable, that's going to determine whether we're going to choose to, I want to say, maybe vagal the patient to try to bring. That obviously would be done if somebody's stable as against unstable. So we're going to look at these just to see what we do. All right. So with any situation, any scene, we want to make sure we're establishing our ABCs. We want to deal with, the circle of life is what we call it. Airway, breathing, circulation. That means we start with the basics. Okay. We're going to more or less get our vitals going. We want to assess breathing, airway, to make sure the patient is breathing. We want to make sure he has a pulse. Your vital signs are going to expose these things. Obviously, your presentation of your patient is going to determine, once you look at them, you can figure out, hey, this guy looks stable or unstable. But more definitively, once you take vital signs, that's going to begin to talk to us. It's going to tell us whether the patient is stable, whether it's unstable, and so on. One of those are like your blood pressure, your level of consciousness, and so on. Okay. So we approach our patient, we're going to assess our patient. He's breathing, he's got a pulse, he's got circulation. We've taken vitals, we've attached our monitor, EKG, pulse ox, get a physical, history, physical exam, etc. So once our 12 lead is done, obviously, we're going to be able to see what kind of rhythm there is. Our 12 lead, which shows something greater than 150, like you saw before on that rhythm that was on the screen, is going to obviously be something we have to do about. As we know, normal pulse is 60 to 100. 150, that means he's stacking out. He's going too fast, and we've got to do something to slow him down. All right, so we've recognized that this patient is stable based on the vitals and the physical presentations. If your patient is stable, one of the things we can do is try vagal maneuvers. We can bear down, and if that does not work, then we go to our medication regimen, which is, generally adenosine 6 and 12. All right, so that's going to be our approach. If our patient is stable, we're going to first try our vagal maneuvers. If we can, go to our medications. One of the do's and don'ts here is do not use adenosine. It's not going to work well. It's not going to do him good. Make throat clot or something if he is in AFib. All right, so we talked about narrow-complex tachycardia, heart rate is greater than 150 here, and stable. Now we're looking at unstable. Whole different approach we're taking. As usual, we're going to hit our ABCs for this patient. We're going to do EKG, O2 sat, BP, history, IVIO. I want to just say as a pointer, do not delay cardioverting your patient for an IV or IO. Okay, do not delay. We want to get that heart rate down as quickly as possible. So if our patient is unstable or symptomatic, we have an acronym we use called CASH. Okay, that will be your chest pain, your altered mental, your shortness of breath, your hypertension, your PE. If they have the CASH, we're going to give them the joules. That means we're going to cardiovert them. We're going to shock them. Okay, that's the thing. If they have the CASH, they get the joules. Okay. All right, so we want to consider sedation if there's time and if the vital signs like blood pressure allows. Depending on the device being used, we're going to sync our patient. Okay, 200, 300, 360 generally. Obviously, there are different devices that we're using. The monophasic could be 2, 3, 360, and your biphasic is generally 100 to 200. Listen, if the cardioversion fails, we have to go back to our medication sequence for stable VTAC. Okay? All right, so that's what we got there for unstable. Again, we want to go straight to shocking them. And if they don't convert, then we're going to go back. We're going to go back to our other sequence. Right? So, like we said before, make sure we do our physical assessment, always taking the circle of life in concern, or circle of life as we know it is what we have here. So, adenosine 612 or cardizem 15 to 20, atenolol 5 milligram, so on. All right, so we're going to look and see. So, we dealt with VTAC, stable VTAC, unstable with a narrow complex. All right. So we're going to take a look at wide complex VTAC that's stable. Okay. As usual, whatever we're doing, we're always starting with our ABCs, apply monitor, EKG, pulse ox, your blood pressure history, physical exam, IVIO, 12 lead EKG. If the patient has wide complex tachycardia, right, wide complex vita, but is stable, we want to start with medications. Okay, want to start with our meds. Procanamide, 20 to 50 milligrams in a minute. That's gonna be one of our go-tos. Amiodarone, 150 milligrams over 10 minutes. We can do sotalol, 100 milligrams over 5. Lidocaine bolus, zero point 0.5 to 1.5. Or we can try adenosine if regular um, rhythm is undiagnosed. If we can't diagnose what the rhythm is, we may try adenosine. It may not work. Again, a tired heart will fail. So most likely, vagal is not necessarily going to work on the wide complex. They're in trouble already. It's not doing much for them. We want to go straight to uh, our uh, shocking the patient. So wide complex, we talk about stable, unstable. By now we know the rules of life, circle of life. We talk about that ABCs. When we know this patient is unstable because of the cash, he's unstable. How do we know? Because of cash, you know, he is unconscious, is his level of consciousness is low. He's got altered mental. He's got shortness of breath, hypotension, all that. So if the patient has the cash, they get the jewels. We're going to start at 100 and increase as needed. Our goal is to bring the rhythms to sinus. Goal is to bring the rhythm to sinus. Again, different monitors will carry different things. Generally, what I've seen is 100 joules on the starts and we increase as needed. And just remember that if the patient is in torsades and which is irregular and wide rhythm, you're going to defibrillate. Okay. We're wrapping it up here on this. Hopefully you guys have a good understanding. So here it is. We're going to talk about how do we use the machine to sync. A lot of times people are not familiar with the machine, you know. So at this point, I would hope we have a 12 lead EKG. We see our rhythm again. We decided to sync. Want to make sure the machine is on. We press the sync button. We look for synchronization at the peak of the QRS, which is generally R wave. Set the energy level, and we press the charge button. Then we push to shock. All right, so we reassess the monitor to see if the rhythm has changed to sinus and increase, in other words, titrate to increase that energy level as needed until we get what we're looking for as far as bringing the patient back to normal sinus. All right, so that's where we have it for unstable supraventricular tachycardia, SVT, rate greater than 150. All initial vitals are done, ABCs. Focus history, 12 lead shows rapid heart rate, unstable periodic vitals. Patient has the cash. We know he's going to get the jewels. So we're going to sedate if possible, and if he's conscious and the blood pressure allows. Again, thank you so much. I'm Garfield Hamilton from PR Health and Safety. Catch you next time. Hopefully this was informative for you and you uh, more than you did.